There have been several large randomized clinical trials, all comparing a newer agent with Revlimid and dexamethasone versus a placebo with Revlimid and dexamethasone, and they have shown a consistent prolonging of the progression-free survival among patients receiving the third drug. There have been issues with the trial's design in several of them, and they really are not as inclusive as I would like. The shape of the curves does differ in some of them for some puzzling reasons in some of the cases. For example, the Ixazomib or Ninlaro Revdex versus Revdex trial shows a separation that appears out of nowhere at 9 months and is kind of stable, and both curves are down going. And then in the trials done with Aspire, there is a separation in those curves, but they continue to go down, and in addition, in both arms, and in addition, they've really tried to treat a pretty good group of patients. There weren't a lot of high-risk patients. These patients had to be responsive to proteasome inhibitors, so they didn't really set the bar very low. They set it very high for enrollment, whereas the trials that have been done with Eloquent-2, randomized trial with elotuzumab Revdex versus Revdex, that trial included patients that were a lot higher risk, and yet we're seeing a flattening of the curve suggesting long-term benefit to the drug. And in my own experience, both on and off trial, I am seeing patients who have ongoing responses with drops that are continuing in their myeloma markers way beyond what I see with Revlimid and Dex. Second year, third year, the numbers just keep getting better, suggesting there's something different here with the use of the antibody beyond simply like another chemo drug, another proteasome inhibitor, another immunomodulatory agent. There's something here.
It's important when you start looking at our different combinations to start thinking beyond our typical median PFS and median overall response rate. And this is a consistent message that we're seeing with many of our novel therapies now. So we historically look at just the median PFS and just the overall response rate. But I think things are changing. I think it's important for our treating physicians now to look beyond just that one line and think about looking at the actual progression-free survival Kaplan-Meier curves. There's a lot of difference that we see in terms of what the kinetics of those look like. We need to look at both the hazard ratio as well as the PFS. I think it's important to look at both of those together. I don't think one individually gives you the whole picture for the benefit of each combination. So it's not only looking at the combination of both the hazard ratio and the PFS, but it's also actually looking at the shape of the curves. I think that adds a lot of value. If you look at two Kaplan-Meier curves that separate but then come back together, that's very different than maybe a Kaplan-Meier curve that separates and remains separated, because I think that starts speaking to long-term disease control as well, saying I'm really getting some long-term disease control and benefit from this therapy for these patients. So I think there's a couple of things when we start looking at these Kaplan-Meier curves with some of our newer therapies to look at. Number one, it's challenging or interesting, for example, with a Tourmaline study with Ixazomib Lendex versus Lendex, the progression-free survival curves don't actually start separating out till 9 months. So they have a late separation, which is different than we'll see with most of our therapeutics, where we see an early separation at 1 month from the two different arms, from the comparator arm or the experimental arm. So again, even though it has a nice 4-month progression-free survival in the final analysis, when you look at those Kaplan-Meier curves, that really adds a lot of perspective and a lot of meaning, in addition to just looking at that PFS and hazard ratio, when you start seeing when those progression-free survival curves separate, for example, and also when they separate but when they come together, or if they don't come together. I think that's very important and really adds a lot of value beyond just the bottom line of the median progression-free survival and overall response rate. And importantly, the other thing when you think about looking at this is when you look at the median progression-free survival, you're only looking at one very specific time point. And so I think it's important when you look at the Kaplan-Meier curves and you look at the hazard ratio, you're looking globally across the benefit across the entire duration of the trial or while patients are on study. So I think that adds a lot more perspective other than just looking at one very specific time point, such as the median PFS, which is important, but I think looking at the global picture, I think is very helpful for our patients, especially as we start looking at some of these new combinations. The other important implication of when you look at median progression-free survival and overall response rates and the type of relapse, as you start applying this, I think it's very helpful when you look, for example, a combination of elotuzumab and lenalidomide and dex. you'll see a very nice response rate as well as a improvement in their median progression-free survival. But importantly, what you see is also good long-term disease control as well. And why is that important here, especially in somebody, for example, with a more indolent relapse? Importantly, because some of these drugs, like our immunostimulatory component of elotuzumab, require time. This is not an active cytotoxic therapy that's going to lead to disease control within the first 2 weeks, for example. And so I think that built on the backbone of, in addition to lenalidomide and dex, which provides that initial disease control as well. But the nice thing that we see with elotuzumab, for example, because of the immunostimulatory component, is that you get to see long-term disease control, which I think is an exciting option for patients. It's not only that early disease control, but long-term disease control as well. And that takes time to train the immune system, activate the immune system. And so for those patients with an early relapse or an indolent relapse or a biochemical relapse, I think that's an excellent option for patients, really to not only get you that disease control early, but as well as late as well. So I think that's an important option for patients when you think about which combinations to use in which patients.